Hello and welcome to our panel on sexuality. We are coming to the close of our two-day conference, and we want to take this time to thank all of our sponsors and panelists for bringing this programming to you. You still have a little bit of time to access the networking lounge in the exhibit hall to interact with our sponsors and other FORCE constituents and volunteers, so please make sure to head over to there. For today, we are going to be discussing sexuality, and I would like to take this time to introduce you to our panelists. Our first panelist is Dr. Sharon Bober. She is the senior psychologist and founder and director of the Sexual Health Program at the Dana-Farber Cancer Institute. Dr. Bober is also an associate professor of psychiatry at Harvard Medical School. Please go back and review her talk from earlier today, Sexuality and Intimacy Issues for Women. Our next panelist is Dr. Andrew Matthew. Dr. Andrew Matthew is a lead psychologist at Princess Margaret Cancer Center in Toronto. He is a clinical investigator in the Department of Surgery, Division of Urology, and a member of the Department of Supportive Care. He is an associate professor in the Faculty of Medicine, University of Toronto, in the Departments of Surgery and Psychiatry. Please go back and review his talk, Sexuality and Intimacy Issues for Men. At this time, we are going to start tackling some of the many questions that have come in today and over the course of the conference. I'm going to start with a question for you, Dr. Bober, and that is, I have no libido after my risk-reducing salpingo-oophorectomy, and as a breast cancer survivor, I cannot take hormones. Are there any non-hormonal methods or medications for improving libido?
Thank you, Elise, and it's really nice to be here with all of you this afternoon. Let me just say that this is a core question that I often hear, and that I'm happy to talk about, because I think that people get very little support around changes in desire, and often we're not really even clear how that happens. I will say that it's actually a really important question, because it gets at the very key issue of what is libido and where does it come from? Is it physical? Is it psychological? Is it in my head? How does that work? And really, in many ways, libido, like sexuality, is really at the intersection between physical, psychological, and relationship factors. It really is very much at the intersection of all of those domains. And for many women who go through dramatic estrogen loss, such as risk-reducing surgery, that is a very significant shift, right, in terms of the hormonal landscape. Lots of women find that, when they go through menopause in a dramatic way, and I always refer to that as that kind of driving into a tree menopause. It is not a natural menopause where your body is adjusting over time. There's an experience of not feeling that desire is spontaneous in any way. It's not familiar, because it's not something that you just have an urge that's automatic, like a light switch. And one of the most important elements around dealing with low desire is, first of all, to appreciate that, yes, hormones have a significant impact. It's certainly an important recipe in the ingredient, but it is not the only recipe in the ingredient. And that often what happens is when there is a change to desire being spontaneous, and we just aren't in the mood, we assume that that is just how it is, and we don't really have a sense of how we can change that. So I think the orientation that we take is that desire really becomes an experience which we have to cultivate. Desire becomes an experience that we need to jumpstart rather than assume it is spontaneous. And there are ways to do that that are certainly again, at that intersection of jumpstarting behavior, like exercise or like other kinds of experiences, where you may not spontaneously be in the mood, but if you get started and you have an experience that feels good, it becomes reinforcing and it allows you to be motivated to want to have more experience in that domain. So the short answer is that I think bringing a kind of mind shift around looking at desire as being spontaneous to something that needs to be cultivated allows us to really take a cue from behavioral activation, being able to sort of think about what does feel pleasurable, how do we re-examine and in a sense survey this new landscape on the other side of risk reducing surgery and sort of figure out what might feel good, what might feel different. How do I kind of get a sense of feeling in myself in this new body in a way that feels comfortable and not panicky. And that might be starting slowly with your partner to really expand your repertoire to focus on what feels good rather than to be goal oriented around having an orgasm or having desire. Because I will say that when we have a lot of pressure and when we feel nervous or anxious that we're not in the mood, often we feel guilty or we feel like we're not being a good partner. That doesn't help us, but in a way it just kind of hampers the feelings around getting started with something. And I would also say from the point of view of a medication, and I think it's an important question, some people say, listen, if I can't take hormones, there's nothing I can do. I think it's important to recognize that, again, although hormones are part of the ingredient, it is not the only ingredient around desire. So I want to fully acknowledge that after we go through significant shift in estrogen, and we sort of lose some of our testosterone, no doubt for women, that is a big change. But I think it's important not to get worried that if we can't take hormones, there's nothing we can do to jumpstart that experience and improve the experience of desire.
Thank you so much. There was something that you said there that particularly resonated and I think will resonate with a number of constituents, and that is feeling grounded in your own body, and being able to not dismiss, but be able to push aside anxiety, or that feeling of panic and moving to a more grounded space. Could you specifically elaborate on just a couple of tools or ways that constituents can do that?
Yes, so thank you for mentioning that. There are really two pieces. One is about what does it mean to feel comfortable? What does it mean to feel whole? What does it mean to feel grounded in my body on the other side of a change, right? And I think that, again, being able to start exploring and experimenting for oneself with whether that is self-touch, with pleasure, with masturbation, with, experiences that are sensual that may not have anything to do with sex or being with a partner, but just, again, whether that's, taking a bath, sitting in the candlelight and appreciating one's body, or feeling like you can be strong in your body, or go dancing or weightlifting, just sort of ways to sort of be in one's body and feel comfortable. It's a really important way to get started, right? To sort of invite yourself into your physical experience in a way that's comfortable. But the other thing I forgot to say, and I think is important, is that often when women talk about low desire or no desire, when we actually start to do a little bit of assessment or inquiry, what we realize is that at some point that person has tried to have sexual activity and it was uncomfortable or painful. And these things are intimately connected. So this is to say that for any woman who has had sexual activity where there are other kinds of secondary side effects from, say, estrogen deprivation, like vaginal dryness or loss of stretch to that tissue, and you've tried to have sex or sexual activity that you used to have and it was uncomfortable or painful, it is not a coincidence that desire often plummets. Most people are not interested in having sexual activity if it hurts. So I would say that for lots of women, the presenting problem may seem like it's low desire. And what we often find is that that is really coupled with an experience around sexual activity that is physically not pleasurable, or that is uncomfortable or painful. And if that is the case, it is critically important to figure out what are the issues that we need to deal with. How do we make sexual activity pleasurable? How do we make sure you're not having pain or discomfort? That's number one. And number two, in terms of desire, if there's an issue in a kind of relationship dynamic where people are feeling guilty or ashamed or frustrated or pressured, that does not help the situation either. So again, that's often there's a piece of work there that might need to be done with a partner, explaining what's happening, allowing people to find a way to start slowly and take the pressure off, because often that is, again, another real ingredient that kind of dampens any desire or inclination to want to be close or intimate.
Excellent. Thank you so much. An incredibly thorough answer. And to segue off of that, Dr. Matthew, I do want to touch on some of those physical challenges that our constituents are meeting that are affecting their sexual health. So this constituent wrote in, I'm a colorectal cancer survivor with a colostomy. I'm getting back into dating. When is it best to tell somebody that I'm dating? What timing is best? And how do I overcome my fears about my first sexual experience with somebody?
Gosh. Well, first of all, it's a real pleasure being here today and talking at Force and being part of the panel. Nice to see Dr. Bober. And so it's funny, I smile because you've started with very challenging first questions right off the bat. I think intimacy desire and libido is some of the most challenging areas to work in terms of sexual health, and it takes time and patience and sensitivity. And then the other is something not too dissimilar in this person's question about colorectal. In the area that we work in, it's called disclosure. And there's a article written by a person by the name of Danielle. I think her last name was Tyndall. She had just written about her experience. She had Hodgkin's lymphoma. I think she was 22 years of age. And in the article, and I remember reading this probably a decade ago, and it changed my experience of what this question about disclosure means. And she said that, when she goes out on a date, right, it's kind of like she feels like there's no kind of discourse for this confession, as she put it. And she would say things like, how do I explain, that I had cancer, what cancer is, what this means for me in the future, what this may mean potentially for you as a future partner. I might have to talk about my sexuality, fertility, fear of relapse, the fact that I can get very tired in the afternoon because of treatment. And, and then she says, how many dates should I have before I bring this up? And, oh, by the way, and I'm sorry. Right. And this is how she described it in that article. And it was just wonderful to take a look at how complicated it is. And I think there is no right or wrong answer, but the idea is that what you've experienced in colorectal and having an ostomy, the idea is that it is still your private information until you're ready to disclose it. And so the idea is that when you start dating, it's really the time at which you start to build trust and intimacy with the other. And once you develop that level of trust, then you may trust that person with the disclosure, with the idea of understanding that given that you've developed this, that person will be sensitive to the issue. So I'm not making light of it, but I don't go out on the first and second date and immediately disclose that my mother's crazy, right? It's something that you develop with that person that you're with, and when you're feeling safer, because you feel like you're closer and connected to that individual, that's when you can begin to disclose, and it's done and it can be done in a more comfortable manner because you don't feel it is as threatening. So there's no date one or date four, but it really does go with how, for lack of a better description, how mature the relationship is progressing, and at that point in time. And remember, you didn't put up your hand to have colorectal cancer, right? And so it's not, to the degree to which you can manage it, it's not something that you should feel shame for. It's just something that you've needed to accept and adapt, and the degree to which you've done so, you can understand that others will also be able to do so.
Can I actually add to that? I love Dr. Matthews' answer. We do these, my colleague and I do these dating workshops at the Dana-Farber. And, one of there are two little tidbits I want to share. One is that it's really important to remember that if you share a little bit of information, it doesn't have to be all or nothing, right? So sometimes it's helpful to be able to say, actually, I've had some health issues in the past, went through cancer, and I'm wondering, if we could talk a little bit about that. If somebody at that point kind of leans in and wants to hear more, that's very different than if they run screaming out of the room, right? So you don't have to it doesn't have to be all or nothing. You can put a little bit of information out there and see what you get back. But the other piece is that if you put a little bit of information out there and what you get back is not interest, right? Or you get a sense that this person is freaked out or doesn't want to be with you or wants to go in a different direction. Let me just say, you saved yourself a lot of trouble, because you're not going not going to want to be with somebody who kind of can't handle or doesn't want to be with someone who's gone through this, right? And that's actually really good information to have, right? So I would say that, if you think about that, the idea of like, well, I shouldn't say anything. Actually, at a certain point, and to Dr. Matthews' point, it's only when you're comfortable to do that you do. But if that person hears this information or hears this part of your story and is kind of turned off or tunes out, I would just say you've just saved yourself some trouble, because you wouldn't want to be with somebody who doesn't have the kind of maturity or depth to be able to handle that experience.
Absolutely. And just to continue along that vein, and I've dealt with many patients, and they'll say, my challenge is that if I bring it up on the first date, there is no second date. And then if I wait too long, then I feel like I've betrayed the person because I haven't let them in on something that's very important to me and potentially to us. And so that's that balance that we're talking about, is that when you actually feel that you're approaching the idea of betraying, the idea is that's a reflection of the fact that you're getting closer and that you're getting more connected. And so that likely, is really just allowing you the experience of saying, look, it is important to me that I talk to this person about it. And then when you begin to do so, just follow exactly what Sharon said. If they run, then you're lucky.
Sound advice. And I will totally agree with you there. So it's a good litmus test, right? So for our next question that came through for a constituent, this has been an overwhelming question that we do get, and it comes from somebody who's in a committed relationship, has been in a long-term relationship. So kind of on the other side of things. This is a breast cancer survivor who has gone through medically induced menopause, and they are asking, they are able to reach orgasm, but it takes much longer than it used to, if it doesn't happen at all sometimes. And they're wondering what can be done.
It's a good question, and it's one that lots of people deal with, not just on the other side of breast cancer, but often just after menopause, right? Where sometimes, what we know is that often women need more stimulation or more intense stimulation. And at the same time, if that tissue is kind of fragile, too much stimulation can start to hurt. So again, you have to sort of find that right balance. But I would say a couple things. It's actually a great opportunity for me to get that important point across, which is that it doesn't always have to be about orgasm, right? And I'm not trying to in any way devalue the pleasure of having an orgasm. But when orgasm becomes the primary focus or the only way that we can kind of measure whether a sexual experience was worthwhile or satisfying, I do think it adds a fair amount of pressure and a fair amount of expectation to an experience, which can actually be very pleasurable without necessarily having orgasm. So I think there's room for a negotiation there. But that being said, we do know that when, for example, women or individuals have more experience with, for example, getting good blood flow to that tissue, you sort of get exercise to that tissue. Often people find that when they practice using a vibrator, for example, again, whether that's for themselves or with a partner, and there is more experience kind of getting back to having nerves firing and blood flowing, that tissue, it actually can become easier to have an orgasm. Orgasm, again, happens as much in the brain as it does in the genital tissue. So there's really a combination of both a physical experience and very much a cognitive, a sort of affective experience. So I think that, again, I hate to sound like a broken record, but we're looking at that kind of that balance, right, between focusing on helping people enhance pleasure, right, which is both, again, happening at in the brain as much in the genitals, and also sort of having a physical experience, which makes the stimulation more comfortable. So to the point of, why does it hurt? Sometimes people, for example, aren't using enough lubricant. Again, want to make sure that the physical stimulation itself is pleasurable. Huge fan of using vibrators, because I think often the vibrator can allow somebody to get more intense stimulation in a sort of more bang for your buck, so to speak. So I think that can be helpful. And I think that, this is where people really have to, with their partner or starting with themselves, just do some open experimenting to figure out what might feel good, what might heighten the experience, what might turn you on. I'm always very aware that when we're in a situation, men or women, and we are feeling self-conscious that it's either taking too long and that tape loop starts playing in our head and you're thinking, geez, my partner's going to get bored, or maybe this is taking too long and what's wrong with me, that really interrupts the whole flow, right? One's no longer in the experience, but one's then having an experience of being a spectator, of watching one's own experience and judging, right? And feeling self-conscious. So I would say good example of how we really have to kind of take a mind-body approach in that situation, and help people really enhance the strategies that they're using and find additional strategies to focus on what is pleasurable.
And related to that, and this is kind of going to be the global statement for this whole thing, and that is the degree to which, as a couple, you can increase your communication about the impact of the cancer and how and the treatments and how it's affecting you, or your sexual health. Is a real pathway towards being successful as a couple, to reestablishing kind of an optimal sexually satisfying life. And it seems simple, but the fact is that if you think about it, especially in this case, we have a couple that's been together for a very long period of time. I mean, if we think back to their beginnings of their relationship, they'll have met each other, and then that relationship will have transitioned to a sexual relationship. And they probably just did things together and kind of listened to the other person's experience, from sounds and the like, and find out what they enjoy. And somehow they got to a sexual routine. And I don't mean just plain routine, but a sexual kind of routine that they were used to as a couple. They may not even have discussed anything about it, just that became part of how they went about it. And then we flash forward 30 years later, and everything's changed, and we're not used to talking about sex, even with our partners. It's kind of an interesting, almost taboo. It's like that's what happens in bed, and we lose ourselves as a bit animal, like pre-man, pre-cave person thing. But the idea is that if we actually sit down and talk with each other in a really sensitive and manner, it can be very helpful for issues such as what's just being said. Is that it'd be interesting to find out what the meaning of the orgasm means for both members of the couple, and it's not uncommon where I've worked with couples where, if it's a heterosexual couple, the male is working. It's very important that he brings his partner to orgasm, and this is, and he feels like he's really letting her down. And then the female partner says, I'm trying to reach orgasm because I know it's so important to my husband, because this is it. And so it gets to the kind of the gift of the magi, right? It's like they're both doing something for each other that in the end, there would be a better process of going about it if they had really nice, open communication about, does every sexual activity encounter require that the orgasm be reached, and what does that mean, and how can we how do we renegotiate that sexual experience? And the other thing related to that is that if the pressure gets taken off, right, then sometimes the orgasms are easier to reach because you're not focused solely on the.
To Dr. Matthews' point, that's what I call the military campaign of trying to have sex, right? So, that is often not a big turn on, really, in the end, right? You need to sort of really kind of have a new chapter in terms of what that looks like.
Yeah, and I also think that speaks really well to what you touched on earlier, Dr. Bober, about the sexual response cycle and making that mental switch for yourself from spontaneous desire to experience that needs to be cultivated. So whether that's through conversation, but there are many of our constituents who do have very physical symptoms that are affecting their sexual health. And one of them that comes up more often in these conversations than not is around vaginal dryness.
Sure.
And so our constituents are wondering, are there specific steps or tools they should be using at home that do not involve medication that can give them some relief from the symptom?
Sure. Yeah, no, thanks for asking. And I know I went to both Dr. Larkin's talk yesterday and the menopause talk this morning with hormones. And I think the point that everybody really is universally acknowledging now, which I'm delighted to hear, because I don't think it was always sort of stressed, is that women need to know how to take care of vaginal health. I think I want to sort of step back and say that's about sex, but that's also not about sex, right? That's just about taking care of your body. So regardless of whether you're sexually active with yourself, with another person, or not at all, it's important to know how to take care of your body, including your vaginal health. And in terms of vaginal dryness, which is a real issue with or without sexual activity, it's important to recognize that women have to get a moisturizing regimen that works for them. And so sort of summing up all of these talks, I think the key is not, do you use vaginal estrogen or don't you? But it's really figuring out what is the right method for you, between you and your doctor, between you figuring out what you're comfortable with. We do have moisturizers that are over the counter that are non-hormonal, in addition to vaginal estrogen, vaginal DHEA. All are on the table, again, in terms of good options. But what's important to remember is that vaginal dryness does not resolve itself. It does not get better over time. So everyone really needs to figure out a moisturizing regimen that is sustainable, that is manageable for them. So I think the key here is whether it is checking out some of the over-the-counter moisturizers. Again, I think it's important to try one product at a time so you know what works and what doesn't, but to really find something that that feels comfortable, that you can use 2 to 3 times a week. Some women need to moisturize 4 or 5 times a week, depending on how dry they are. But that it's a really important point, because if you're uncomfortable and that tissue is dry, it's a limiting factor in so many things, not just, about sex, but other kinds of physical activity, riding a bicycle, etc. So I think the key is about using a good moisturizer, getting a lubricant that feels comfortable during sexual activity, that feels natural. We have so many products on the market now that are so much better than just the limited number of options even 10 or 15 years ago. And, I think that there are lots of good resources online if people are looking for specific recommendations as well.
Yes. I'm going to ask a very similar question to you, Dr. Mackey, because we did have this come in from a constituent, but it is related to erectile dysfunction. And that is that it's gone untreated so far for this constituent, but they are ready to step into treatment, but just don't know where to begin and what their options are. So if you could give a brief overview of kind of what the medical options and treatments are for erectile dysfunction, that would be very helpful.
Certainly. So one, just to remember that if this is cancer related, your oncologist or the clinic, there's really no question that that a person should feel uncomfortable asking about their cancer and the treatment and the side effect profile, and that is also specific to sexual health. And so, bringing up the fact that you're experiencing erectile dysfunction with the clinic is very important. Hospitals have varying levels of sexual health support, but we can take a look at, it depends on the type of treatment, and that will reflect the type of erectile dysfunction that's being experienced. There's if it's a surgery to the pelvic region, they can have the nerve bundles can be disrupted by the surgery. It's not kind of an on and off switch. There are times when they have to completely sever those nerves, but that's the rare case. So you can have some partial nerve sparing. And that's why there's some real differences in the way men will respond to certain pro-erectile agents, which I'll get to in a minute, because it all depends on the level of damage and recovery of those nerves from surgery. Radiation to the pelvic region can cause some brief erectile dysfunction during the active phase of radiation, but it usually actually reconciles. But radiation is known as the gift that keeps on giving. It will have an effect often in the second year after treatment or third or fourth year after treatment. What we try to do is we try to treat with the least invasive method through and then continue on, and also match what are the desires of the patient. If a patient just wants to kind of maintain their penile health for a period of time and let the recovery occur more naturally over time, then we'll start with a very with a least invasive method, such as a PDE5 inhibitor. Those would refer to Cialis, Levitra, Viagra. If someone wanted, erections right away up front, then we might go to something more invasive like ICI or intracavernosal injections, which are actually injections to the penis. So we'll go backwards a little bit. The PDE5 inhibitors can be very successful. It is important to learn how to take them. So it's not just that you take the box, you go home and you pop one in your mouth and it works. It takes, you need to get the correct dosage, but they also generally like an optimal situation. So the idea is that they don't like the presence of alcohol for the most case. They need digestion to have occurred in order for the agent to be saturated for its optimal dose. They do have side effects related with them because they're small blood vessel dilators, so they can cause headaches or congestions and other side effects. So it's important to work with your physician, and you can even go to your GP if they feel comfortable enough to work in the arena, knowing the cancer background. And then you could move to Muse, which is a microsuppository, which is a little tiny agent that you can slip into the tip of your penis through the urethra, and you massage it in. And it's a localized agent, so it doesn't require the nerves that may have been injured during your treatment, and that can be useful in about 50% of men. Then there's the injections. They're actually extremely successful in the 90+ range. And the bark is worse than the bite. The idea of injecting your penis usually turns men off almost immediately. But it's a very small gauge needle, not bigger than the needle you get, for instance, for a flu shot in the arm. The shaft of your penis really doesn't carry a significantly more sensory nerve bundles than your arm. The tip, of course, does, but you'd never inject it in the tip. And men who utilize the injections are often quite satisfied. So that's an option. But for this person, it's okay that they're 4 years or 5 years out. We've tried very hard to determine that if, early upfront return of function or use of pro-erectile agents is super important for long-term health. And the fact of the matter is the data just doesn't bear that out to a great degree. We want to keep the penile tissue healthy. But the idea is that it's perfectly fine 4 years later. I would suggest earlier, because we don't want it to stay, not focus on that particular part of your sex life or erectile functioning earlier on. But this gentleman can certainly go back and try to go through that process. The other final one is obviously the vacuum device, and it's an excellent option for those that do not want to engage in any kind of medication.
Excellent. Thank you. Very thorough answer. So Dr. Bober, this constituent is writing in, and it's actually a question that's come up in the chat multiple times here, and it's about those long-lasting psychological effects. So when we talk about body image, or when we talk about surgeries that have done and people are feeling disconnected from their body, they're feeling disconnected from their breasts, they would like to know what methods they should put in place in order to get themselves psychologically out of the stage from being in survival mode to getting back to their sexuality.
So it's a good question, and I can't say that there's one stop shopping easy answer to that, right? But I do think that this is it's a good segue to talking about how we really need to be able to do that kind of mind-body work, right? We really need to be able to sort of help people think about the raft of automatic thoughts that are often cycling through our head and that really are distracting, right? So lots of times, first of all, let me just say, how we think has a big impact on how we feel, right? And when we are when we are engaged in any kind of, potentially intimate encounter, I don't think it's a coincidence that often, as opposed to when we're running around going through our day, multitasking and doing 1,000 things, we don't think about these things, right? But that somehow all of a sudden, when it's quiet and when with one's partner, and all of a sudden, all of the distraction of the day kind of melts away, that all of these automatic thoughts about fear, about our bodies, about death, about cancer, all of a sudden become very present. And I think that it's also a really important point to make, that often we feel like a hostage to our thoughts. It's kind of like, oh my God, I can't stop thinking about this stuff. It's distracting. How do I stop thinking about it? We use a lot of mindfulness based therapy in the program that I work in, because the point is that often when you are at war with your own thoughts, when you're telling yourself, I can't be thinking about something, you think about it more, right? And being able to work with, whether it's a therapist or a counselor, to be able to sort of help get some clarity around how to let go of some of the judgment and the intensity around some of these very big thoughts, but how to be able to invite yourself to notice them, become aware of them, and then essentially let them go, detach from them, so that they are not like a drumbeat in our head. It's a very important aspect or element of how we can become present to our current experience without being distracted by this sort of chattering monkeys of thoughts and voices that are kind of constantly in our heads. So that was a very poor summary of what sort of, we sort of think about when we talk about mindfulness and intentionality and thought and action. But the idea is that when people say to me, how do I stop thinking these thoughts? My first question is, it's not really about, do you really have to stop thinking about them? Or can we sort of change our relationship to these thoughts that come and go, and how can we really sort of allow you to heighten and focus your intent, your sort of intentionality and your intention and your real experience of being in the moment, right? Whether that's with yourself or with a partner, without feeling distracted by something that is circling in the back of your head. And I think a lot of the time, the key is being able to not beat up on yourself that you might have certain thoughts, but to have a greater sense of compassion for oneself, right? To be able to have a sense of compassion that it's normal, that people can have all kinds of worries and thoughts and fears that bubble up, but then to recognize that we are able to sort of notice them and keep going, rather than feel that, oh my goodness, that derails the whole experience. Does that make sense? That often the feeling is that if I'm having that thought, then I get distracted, it ruins the mood, I'm done, I'm out, I can't participate in something anymore. Whereas if we can take a very different approach that says, listen, I'm going to assume that there's going to be all kinds of thoughts that come up. It makes sense that you're going to have all kinds of thoughts that come up, but can you kind of have enough compassion for yourself that you're able to pause, notice them, and then kind of keep going, or be able to sort of then refocus yourself back to a very real experience of sensuality or pleasure that feels safe, that doesn't feel scary. It's a very different approach than saying, how do I just not think what I'm thinking? Or how do I just not think those thoughts that keep coming? I mean, again, I'm very ineloquently describing what I think is a very important strategy around some of this, which is really what we think of as kind of mindfulness-based therapy, mindfulness-based cognitive therapy. But it's really helping people, I would say, expand or redevelop their relationship to many of those thoughts that keep bubbling up.
And you did mention sexual therapists, and Dr. Matthew, you did briefly before mention talking about your provider team. We do have a number of people asking how they can find sexual therapists in their area, specifically if you are a couple who are both experiencing or going through a hereditary cancer journey and are both not feeling sexually connected to your own bodies or each other. What resources can constituents access in order to find help in their immediate areas?
Andrew, do you want to start with that one?
You start, because it's probably going to be more in the US than here, but let's try what's the US answer?
Okay. Well, what I would say is that the good news is that there are many more resources now than we've had before, right? I mean, I get emails constantly from people saying, we're starting a sexual health program at a cancer center somewhere. Can you help us? So, obviously this isn't something that's, everywhere you look, but I would say that many of the major cancer centers have therapists, have psychologists who are doing some of this work, who have programs, and more importantly, have websites with a lot of information online. I know that we have a number of major organizations, whether it's Force. I mean, all the talks I've given are on the Force website, right? So there's plenty of information that is now kind of digital, which you can, reach through organizations like Force, Living Beyond Breast Cancer, the Movember Foundation. Andrew and I have worked closely on a project that's for couples after prostate cancer, that's sort of sponsored by a foundation now through the University of Michigan on their website. So we definitely have resources that we didn't have before that people can access online. And I also think that often there are individual sex therapists, counselors, psychologists in one's community who have experience working with whether they're cancer survivors, previvors. I'm not going to be naive. I do think sometimes people have to interview a number of folks to find the right person. But I would say that, in the field, there is now more training and more attention to this than before. So I think that there are a larger number of folks who are familiar with some of these issues. And the other piece is that, people can't be shy about advocating for themselves. So if you go to go to a doctor and they say, do you have someone that who can do some of this work? And they say, no, don't stop, don't give up. People often ask me this question. I am excited that more people are focused on cancer and sexuality than ever before. So I think we have more people who are doing some of this work. And I think it's possible you might live in a community where there isn't someone, but this is where I would say getting online, whether it's for the Dana-Farber, Memorial Sloan Kettering, Mayo Clinic, the University of Chicago, all have really rich resources that are readily accessible and free. So that would be a place to start if you can't find somebody in person. Andrew, how's it like in Canada?
Yeah, well, I mean, it's similar. And I think an important point, your first access point, hopefully can be the institution in which you received your cancer care. Many, and believe me, this is remarkably changed in just the past 10 years. So many will have some form of resource. All right. The other thing is to remember is that the psychologists aren't just one type, and social work and sexual health counselors are not just one type. For instance, for Sharon and I, when we register as psychologists, we're broken down into, are we working with adults, adolescents, children? Can we work with couples? Can we work in health psychology, in clinical psychology? And we register in each of these areas. And so I think to the degree to which you have choice, and depending on where you are, the more you can find somebody that that works in health, and then that works in sexual health, and then hopefully in oncology, right? The better off the service you're going to get. So take your time to find the right person. It may cost some money. Let's say it costs $200 an hour or something along those lines, if that's the way, and may not be covered. But imagine if your knee surgeon said, you need a brace, and that brace costs $1,600, it would take you 2 seconds to buy that brace. And that'll buy you a number of sessions that can help you about something that's very important.
To that point, we did have this question come through a number of times about covering costs. So specifically, this constituent wants to know, do health insurance companies typically cover costs for vibrators or other devices used to increase libido or sexual satisfaction when it is a relative symptom or side effect of treatment?
Not that I know of. I wish they did. That would be a really good thing. We hear from men all the time that insurance might pay for 4 Viagra a month or 6 Viagra a month, when we think, well, from a kind of a penile rehab point of view, we should be using low dose daily, right? So there's a disconnect there between what gets paid for by insurance that's considered, like recreational sex toy versus what we think of as being actually therapeutic or rehabilitative. So I can't say that is the case. I don't even know if FSAs, cover vibrators. I'm not really sure about that. And I would say that's a it's a really frustrating point, right? Because the fact is, something that somebody else might be thinking of as a sex toy may well be actually a therapeutic from the point of view of rehabilitation. But I can't say that for sure. I would say, on the other hand, it's worth asking your insurance company. And we know that lots of times people do petition insurance companies to pay for something. And perhaps if that purchase is made and you have a letter that comes from, whether it's a gynecologist or a urologist or a psychologist, that says that this is actually for rehabilitation, you might be able to get reimbursed. So I would say that's definitely worth at least trying to get reimbursement.
And a lot of oncologists will have those letters available for you that they'll sign off. The degree to which they help, who knows, but at least it's something.
Excellent. Thank you. Well, that wraps our session here today. I'd like to thank both Dr. Bober and Dr. Matthew for fielding all of our questions and providing such thorough answers. Thank you to all of our attendees for sending in your questions and being so active and engaging on our platform. We only have one more session left for our conference, and that is our closing Q&A. So make sure after you wrap up here that you pop over there, and please do fill out your session surveys to provide us feedback so we can continue to shape and improve our force programming. Thank you so much, everybody, and have a wonderful rest of your day. And we'll see you at the closing session.
Thank you. Thank you, Elise.
Thank you.
Thank you.